Okay, so I think I've got the tech working. So thank you very much, Rajam, for inviting me to speak at the San Diego Pain Summit. And my session today is a slightly provocative title, and it's just get on with it, an exploration of the ideological, interventional, and experiential meanings of self-management of chronic pain. That's just a lot of words that I came up with to try and sum up what it is I'm trying to say when I'm talking about self-management. But hopefully by the end of this, you'll all be with me. And I'd just like to start by declaring my conflicts of interest. So I am a DPhil or PhD candidate at the University of Oxford in their Department of Primary Care Health Sciences. I am funded for this via a fellowship from the National Institute of Health Research in the UK. And I am employed as a clinician at University College London Hospitals NHS Foundation Trust as a physiotherapist and a doctoral research fellow. So I'd like to kind of just get started by sharing a little bit of my story as to how I got into self-management. The main part of which really is associated with my work. So I'm a physiotherapist and I work with people experiencing pain. And from my memory, my first encounter with the term self-management was when using this in a clinic, in discharge letters when writing back to my patient's primary care physician or their general practitioner. And the template we used had a series of short phrases to help speed up the completion process. And after you'd kind of written everything about working diagnosis and the presenting problems and the nature of the intervention, many letters ended with the phrase, "So-and-so is now successfully self-managing, and I am now discharging them back to your care." So in this setting, self-management referred in some way to the patient now being independent with their home exercise program usually, and no longer needed to continue working with me. Now, this decision was influenced by a whole range of issues. So there was an unspoken understanding that working in heavily subscribed public and nationally funded services in an inner city area, there was a high demand for the service. And I was very much aware of this. There was also a tacit understanding that we weren't going to be keeping patients on for an extended period, especially if sufficient progress was not being made. And the progress was determined by myself as a clinician or by my supervisors or senior staff. And this was also enforced by having regular case review sessions with a senior clinician, and we talked through cases that had perhaps more than 4 appointments. Now, these sessions allowed me the space to think through and problem solve any stagnation on the progress and to plan a discharge. I had the privilege to work with a clinical psychologist, and we often spoke about endings and managing boundaries to stop patients becoming dependent on the service. And we also had a strict attendance policy that dictated that if a patient missed more than 2 appointments, we would discharge them. And this was another point in time that all of us made a judgment on a person's willingness to engage. And there were similar episodes where I, as a clinician, made a judgment on my patient's ability to manage without me. I used a series of self-report questionnaires that you will be very familiar with and rooted in behavioral psychology to assess a patient's self-efficacy, as this predicted their ability to participate in the interventions, as well as their potential outcomes. And we, as many of you will have done, had various ways of assessing a patient's suitability for further treatments. So with those deemed to have greater potential, more likely to be offered the group programs, onward referrals, and additional appointments. And over time, the role of self-management in guiding these decisions became more explicit. For example, discussions in multidisciplinary team meetings about a patient's suitability for engaging with a self-management approach. And now these days, self-management is used frequently in my clinical world, in policy documents here in the United Kingdom, and in directives, research and opinion pieces, as well as on social media. And more often than not, there is no explicit explanation about what the commentators mean when they say self-management. And so I've been examining self-management as part of my PhD, and I want to present and talk to you about some of my findings and some of the narratives about self-management of chronic illness and chronic pain specifically, and then linking this to a wider discussion, as you will see. So I came to my PhD topic quite simply, and I'm not going to talk too much about this picture, but generally the idea, we're all very familiar that chronic pain is an increasingly problematic public health issue, where a lot of people, and here I can quote the statistics for the UK, between 1 in 3 and 1 in 4 people are living with chronic pain, and about 14% of those have severely disabling chronic pain. Now, that basically suggests that majority of people are doing something that we call self-managing. They have low disability and they're high functioning out in society. The rest are taken care of here in a national health service that is publicly funded by tax. And within that, different practitioners will offer different interventions. The accepted avenue for people who are experiencing more severe pain is to attend a pain clinic. And whilst they're there, they're generally assessed for different types of interventions, but the mainstay is to attend a pain management program where a typical self-management approach is offered. Now, my initial research question was to try and understand how people who were not within these specialist services, how were they managing to do self-management without specialist support? And how were they ending up in this place of recovery and rehabilitation? And this kind of led me to think a lot more about what I meant by self-management. And at this point, I turned to the literature. Broadly, just to give you a sense of what happened, is the literature on self-management of chronic pain is actually quite sparse. So there's not a lot of information out there on this particular topic. But what I wanted to talk through was the literature of self-management of chronic illness and kind of guiding through a historical perspective and see how where did we end up in terms of looking at self-management within chronic pain. And as you'll notice, I have a couple of notes on a slightly different screen. So forgive me if I kind of veer off to the left every now and then, or to your right, I think. So back to the topic. So self-management of chronic illness. Now here's a timeline for you. So in health policy in the UK, and by health policy, I mean what kind of central drive, what government or national policies are driving what is going on. And so for the first time I can identify was in 1999, our chief medical officer at the time committed to a self-management program approach to address the needs of people with disability. And prior to that, like I've said, the National Health Service was essentially more of a welfare and socialized state, though I think that means slightly different things in North America than it does here, but essentially the state provided healthcare for the majority of people, and that's how it was provided. So this was the first time that there was a discussion of of an individual managing their own chronic illness. And then this continued in 2000 with the publication of a couple of documents. So the NHS plan being the primary leader on this. And this kind of put out that the NHS was a resource that would help people, that people would use to help themselves. So the language really shifted then. And at the same time, there was an introduction of this thing called Nhs Direct, which is a phone line that people could ring up and get advice on their health problems and kind of be directed to more different kind of parts of the health service. So taking the kind of adding another step, instead of going directly to your health practitioner, you could ring up Nhs Direct. Now, in 2001, here in the UK, was the implementation of the Expert Patient Program, which, for those of you familiar with the North American work of Kate Lorig over in California, it's quite near where San Diego is. So she works on the chronic disease self-management program, and that had been embedded well within the health system and had some really good, promising outcomes in managing chronic long-term conditions. This was based on a lay-led, so not led by healthcare professionals, but by people with lived experience. And they had a formal structure with which they followed. And I'll say this a little bit more, I'll come back to it, but crucially, the chronic disease self-management program is embedded within a tier system. So there is a situation where people with more severe issues have case management, those slightly less severe have disease management, and then those with not so complicated issues then fall into this self-management issue, and that's the majority of the people. And that's an important point that I want to come back to. And so in 2005, I'm jumping 10 years ahead there, this idea of supporting self-care as a thing that could then improve your quality of life and improve your health was promoted again in policy documents, very separate from well-being. This was now considered a health issue. And so if I then take apart a couple of those issues around what is self-management as an intervention. So based on the context I've just given you of the health policy in the UK as imported from the chronic disease self-management programme, what we found, or what we know, is that there was a difference between lay-led programs for self-management and professional-led programs. So primarily the lay-led ones were pitched as promoting self-confidence. They could be condition specific, or they could be more general. They tended to be condition specific in the US, and in the UK they were more general. They had varied group formats, but generally they were groups. And they kind of promoted this idea that there was a cost savings when compared to healthcare professional-led programs. And they tended to cover a broad series of topics from sleep, nutrition, fatigue management, etc., as well as issues related to specific disease that they were talking about. And attendance was self-selected, i.e. the patients would choose to attend on their own. They might be signposted by their professional, but they would need to do it themselves and get themselves signed up and to attend. And in contrast, the professional-led services focused more on imparting technical knowledge, and that includes psychoeducation or anatomy, physiology, that kind of thing, mostly condition specific. Given the technical side of the information, it tends not to be so valuable if it is generic. Again, a varied group format, and the content varied. And the professionals select the content. They decide based on their expertise and on the research what it is that the program would consist of. And the professionals also controlled entry and exit into these programs. Now, in terms of the effectiveness or efficacy of these kind of conditions, I'm now speaking specifically about the expert patient program here in the UK. And this paper by Wright et al. Really kind of talked about the practical effectiveness things around quality of life, attendance, healthcare utility, how much people were continuing to see their general practitioner, emergency visits and things like that. And then on top of that, this further paper by Jennifer Newbold and team really summarizes the impact of a review of the evidence at the time. And what they found collectively, but reported in slightly different tones, was that there was very little or moderate changes in the UK context versus the more promising findings from the LORIG studies. They reported that there were difficulties in recruiting, and of the people recruited, there were low numbers in terms of men, non-English speakers, and people with lower levels of literacy. And this seemed to be important because the people attending had higher levels of literacy, and that was considered important in the evaluation. And people experiencing underprivilege or underprivileged were less likely to take part when they looked through the health economics of this group of people. And the long-term benefits were limited, though the first paper reported them as really promising, but once the overview of the further evidence suggested that long-term benefits were indeed limited. And there were critics of this kind of model, mainly related to those exclusions that I've talked about. So it was felt that health inequalities may increase due to the skewed uptake, so people might not have access to it, and that proponents and advocates for the approach, perhaps driven by political ideology, may have overstated the benefits of the program in order to get that implemented. And there was also this issue of self-management support that cannot begin and end with a class. This idea that the intervention was this standalone, simple thing. And this was from the architects of the chronic care model on which the chronic disease self-management program that I've talked about is based on, that tier system. So they're saying you can't just pick up the self-management component and assume that it'll be effective. What they said was this requires a whole systems perspective, that the patient needs to be included, the professional, and issues around structural, societal things were taken into account as well. So things such as access to services. Critics also talked about that self-care as a concept and self-management were really conflated, and that it was really difficult to understand what it is people were talking about, particularly as this change to using self-management happened so insidiously. It wasn't very specific. And there were also critics saying that as patients, they've always been doing self-management, but that hadn't been valued until it was taken on or appropriated by health professionals. And I think those critiques are important when we kind of look specifically now at the pain context. So self-management of chronic pain, like I said, is something I talk about all the time in my clinical practice. And I'd like to just go through a little bit of a summary of the kind of things that I've found. And just to give me an opportunity to have a quick drink of water, and if you've got time, whatever it is you're doing, is just consider this statement. What is self-management in the context of chronic pain? Just take a minute to think through what this means to you. I've put answers on a sticky note, but obviously you do not need to do that. All right, so moving on. So as part of my process of trying to understand pain self-management, I did what many people do. I went into Google Scholar and I typed in pain self-management. And as you can see, there are a lot of results. So pain self-management is indeed a very well-used term, high numbers of citations, lots of interventions are being evaluated around this. And it essentially seems like an important topic for me to consider. Now, for my own work, what I've done is looked at the literature from a couple of different angles. So I've not really focused on effectiveness of self-management. I've really tried to understand what is it that people are talking about when they talk about self-management of chronic pain. And I've used a slightly sociological lens to look at this, so really paying attention to how people are saying things in their writing, in the research, in the policy, as well as what they're saying. And what I'm finding, these are preliminary results, I've not written it up yet, but the first thing is that pain self-management is a desirable behavior. So healthcare professionals talk about this is something that they would like to see their patients doing. But further than that, there's not a lot more detail on that. And I think this is in keeping with pain management being really closely linked to a behavioral, psychological way of thinking in terms of its approach. The other thing that's come up is that self-management is considered an intervention, particularly in those research studies that I pulled up on Google Scholar, usually in the form of pain programs or pain management programs or PMPs, where a lot of different interventions, so a complex intervention is delivered to a group of people living with pain or patients, depending on your context, and that forms the intervention. It's also talked about as the intended outcome of other complex interventions. Like I said in my own story, is we used to write letters to our general practitioners and say to them that this person has achieved this thing we're calling self-management, without really saying what that was. But I think that seems to mean that they're not coming back anymore. And I think this is where the title of my talk about just get on with it really starts to hit home. The other part is self-management is a practice done by people with pain. So they are living their whole lives and they are with themselves 100% of the time, and they only interact with health professionals for a very small proportion of that. What they do in that time has really not been deduced or discussed or really illuminated in many ways. We see people talking on social media or via their own media, such as blogs, about the practice of self-management. But in terms of empirical data, we do not have that just yet. It's also, self-management is also talked about now, linking back to that history of policy, as a cost containment measure. So the areas where self-management seems to be talked about a lot is more high income countries or high to middle income countries, where they have a growing elderly or older population. And that means more chronic illness rather than life-limiting infectious diseases, though I hesitate to say that, as we are in the midst of a particularly infectious issue right now. But based on the history and speaking quite broadly, that these countries are faced with an economic time bomb, and therefore there's a sense that the shift to self-management reflects an affordability issue of, if we get people to do more stuff themselves, then the state does not need to provide that. And another kind of idea is that self-management is everything that is not biomedicine, but that is contentious. So, for example, a patient might say they take medication as part of self-management, but when I was speaking to practitioners in my interviews and in my looking through the policy and documents that people provided me, they seemed to speak about everything that was self-management was not biomedicine. So it was not injections or procedures or medications or surgery. It was a collective term used by some of my participants to describe everything that is not biomedicine. So all in all, not that helpful, but what I'm kind of getting to is that it's widely I'm stammering. So it's widely accepted as important, valid, and necessary within pain management. So, but what is it? We're not entirely sure. It is not well described even by people who are researching this particular area. There are assumptions that this is a consensus, that there is a consensus view. And by this, I mean that most people assume that if I say self-management, you say self-management, we're talking about broadly the same thing. So this notion of things that are self-evident, received wisdom, or things that are taken for granted, really fulfill the criteria of a discourse. So when you're looking through a sociological lens, a discourse is an idea that is self-evident, that is received wisdom and taken for granted, that does more work than you would think on a face value. So drawing now from some of the work that's been done in, not specifically for pain, but I found it a really helpful way to try and make sense of my data, which I was finding. So all these different ways of thinking and talking about pain and self-management. Now this first paper here is from 2011. So we're really looking at, this is an Australian paper where these authors really almost did the exact same thing that I did, and they just wanted to understand self-management in the context of the sociological and political environment. And what they kind of found, they did a critical review of the the information and the documentary policies, etc., from a set period of time. And I'll leave you to, if you wanted to go ahead and find the paper. It is quite an interesting one in terms of the history of self-management more broadly. So early self-management, they found, was something very different to what we're experiencing now. It was seen as something that was related to mutual aid and social embeddedness and citizen participation and emancipation, and removing the patient from this dominant socio-political systems. But then in the 80s and 90s, this idea of cost containment that I've previously mentioned, and the self doing a little bit more work on themselves and self-monitoring started to come through. And they kind of came up with these three ways of thinking about of self-management. And the first is, like I said, is self-management as a cost-cutting mechanism. Now, it's the way they kind of described it was that it implies personal responsibility for your illness, that there's something about morality and a moral responsibility and a duty to do your self-management for the greater social good. And those who do not act as expected were viewed to be a problem or seen in a problematic way, and they needed education or training. Now, this can be seen a little bit in a punitive way because you're rewarding only those who have seen to be good self-managers. And this really resonated with me because in pain management, we make a lot of decisions about who to let in. So, and I think while we're doing this, we are making judgments about whether people are acting in a socially sanctioned way, a morally responsible way, etc., etc. And these authors kind of contend with the issue that approaching self-management in this way can accentuate inequalities and marginalize those who manage differently or who face greater challenges in doing self-management. The second domain was this idea that the emergence of the healthcare professional as the expert in self-management. And here there's an assumption that applying predetermined set of self-management strategies by the patient, determined by the healthcare professionals, will result in an improvement in quality of life, satisfaction, and health status. And the researchers have concluded that these disease-specific expert-led, like I mentioned earlier, is much better than the generic lay-led programs. And there's an issue of that being problematic. And the third definition that they kind of talked through was self-management as emancipation. And this is on a more positive slant, whereas the last two are a little bit more critical. And this was seen in when patients or consumers, as they talk about patients, they talk about their lived experience in a very different way from practitioners and policymakers. So for them, self-management as a term would be quite unfamiliar, but they were constantly doing their day-to-day activities in a way that was giving them some freedom from the healthcare system and giving them some independence. Now, again, they kind of focus a little bit more how self-management may need to be thought of differently as either social self-management or a collective way of managing. This is a very different way from the policy and from the healthcare professionals, where they focus on individual responsibility, but with people with lived experience, they think about it more as a collective endeavor that may or may not include healthcare professionals, but will include a wider network of friends, family, religious faith, etc., etc. Now, I'm not going to go through this a little bit. I'm just putting it up there just so you will have the reference should you wish to look it up. But this is another paper from Australia. And if you look at the date, this is 2002, so it's a while away now. But they really doubled down and nailed this idea of individual responsibility and this move towards talking about morality in terms of how individuals take care of their own bodies, and how the state had a little bit less to do with this. Now, depending on your own persuasion, this might be something that intuitively makes sense, or it might be something that you have not thought of before, but I think it's just something to think through. And what Galvin really goes through is some of the differences between self-care, the good self-manager, as I've mentioned, and introduces this idea of self-management support, where the healthcare professional is in a more of a collaborative role with their patient. And I'm going to end on this paper, which is a favorite of mine, and this is the same issue of self-management, and these authors looked at it from the context of stroke care and rehabilitation, and they've done a lot of work in this area, particularly Professor Fiona Jones, who is based here in the UK, around self-management and what that looks like in the context of stroke rehabilitation. And this paper did a thorough job of really looking at some of the, so they looked at secondary analysis of interviews and focus groups that had been conducted for a slightly different study, and they paid attention to issues around power. Now, I'm not sure if you're familiar with Michel Foucault, and I'm going to be very loosely referencing this, bearing in mind that there'll be people who are much more embedded in this way of thinking than I am. But a Foucauldian lens essentially just means they attended to issues of power and governmentality. So what's the role of different forms of power and different ways of how the state works in how self-management works or is operationalized in stroke care and rehabilitation. And from their perspective, some of the things that they kind of summarized was, this is like a slide that I'll just let you read, but I'll read it out in case people aren't got the video. But they summarized that through their detailed analysis of discourse and power, that self-management is a highly nuanced and complex concept. It can fluctuate in its conceptualization depending on the structures, routines, and the individual. And they encourage us, so healthcare professionals, policymakers, etc., to reflect on these complexities, to make transparent their assumptions, and to make it really clear what their own position is as they practice, so that people know what it is that they're talking about. And I'm just going to go through the type of power structures that they found out briefly. So focus was rhetorical power, so how self-management can be used in a really persuasive way. Hierarchical power, so who kind of holds the power there in the dynamic of self-management and stroke? Is it the healthcare professional, or is it the person in their own environment with family? There was personal power, and there was mutual power. So this is the first time that we're really starting to hear a connection between what self-management may have started off being, where it ended up, and kind of where we're going to at the moment. And it's not in the pain literature, but I think until us pain people catch up, I looked far and wide to kind of get a theoretical lens through which to make sense of my own data. And so to finish off my talk, I have a few questions for you, and they are probably not to be answered right now, but maybe some reflections for you to take away as you go about your day-to-day practice. So based on everything I've talked about, does having this default unchallenged view of self-management in pain prevent other approaches from being explored, discussed, and practiced? In other words, is there another way of doing self-management? And does this kind of tendency to assume personal responsibility and individual choice lead us away from wider discourses or ideas that reflect cultural and social systems in pain management? Does this dominant discourse serve to offer up legitimacy to practitioners who do not deviate from the state-sponsored narrative of self-management. And by that, I just mean that, do the people who go along with this personal responsibility in some way get supported by structures such as evidence-based practice and evidence-based healthcare, payment systems, insurance providers, etc. And if you deviate or do something different from what is considered the norm, does that mean that as a practitioner you suffer from illegitimacy and you might not get referred patients or clients, etc. And finally, in doing so, does this disenfranchise people who choose to self-manage their own condition in different ways? So if they do not have a behavioral approach to, say, exercise and activity, and they might do something that's considered a little bit less mainstream or accepted, this is where you can think of what are called in the literature alternative practices. So there might be people who choose to use different ways to self-manage their problem, but if they spoke to a practitioner, would that be considered okay? And yeah, so finishing quite abruptly there with a series of questions, and hopefully give you some time to think it through. What I'll do is I'll provide Rajam with the references in a more accessible format if anyone wanted to read those, and just finish off by saying thank you to my supervisors who guide me in my thinking. If you wanted to get in touch, I think the easiest way would be on Twitter, and that is my Twitter handle. Thank you.